This is Dr. Ravi. I am a consultant nephrologist and transplant physician at KIMS Hospital, Secunderabad. Today I am going to talk about pedal edema. What are the common symptoms? What are the causes of pedal edema? How we need to evaluate it, and what are the treatment options? So generally, edema is accumulation of fluid, mainly due to excessive fluid collection in the interstitial space. So generally, this can present in unilateral or it can be bilateral. Unilateral is when edema is noticed in only one leg. It is unilateral, or it can be bilateral also. So patient can have symptoms that can be slowly progressive edema. When this edema is progressed from the legs to whole body, what we call it is a anasarca. That anasarca is nothing but generalized edema of the whole body. So generally, what are the common causes of this edema? So why this edema happens generally? So edema can happen mainly because of the increased capillary interstitial hydrostatic pressure. Whenever there is accumulation of salt and water retention, that causes increased capillary hydrostatic pressure, ultimately causing transudation of fluid into the interstitial space. The other mechanism is like whenever there is a decreased oncotic pressure, again there is transudation of fluid from the capillaries to the interstitial space. The third mechanism is increased capillary permeability, which happens mainly because of the local inflammation. So these are the three major mechanisms of edema, whether it is decreased oncotic pressure or increased capillary hydrostatic pressure. The third is transudation of fluid because of the excessive capillary permeability. So generally, the common causes of edema, mainly whenever it is a unilateral edema, we need to think of any venous obstruction or it is a lymphatic obstruction. Whenever the fluid is draining from the venous circulation towards the heart, there is blockage either because of the chronic venous thrombosis or acute venous thrombosis that can cause edema of the legs, which is usually commonly it is a unilateral one. Or sometimes this lymphatic obstruction because of some malignancies or some conditions like filariasis that can also cause a edema in one leg, unilateral. Usually this is a unilateral one. So whenever there is edema bilateral or in the both limbs, we need to suspect a systemic disorder. The most common causes being a renal conditions, kidney related conditions or liver conditions, hepatic conditions like cirrhosis. And third is the congestive heart failure because of any cause. It could be some cardiomyopathy or like coronary artery disease. So these are the systemic conditions usually associated with edema of the both bilateral pedal edema. So coming to the other systemic diseases like hypothyroidism also can cause mixed edema, what we call that is a non-pitting edema in both lower limbs. This is mainly because of the accumulation of the myxomatous tissue, deposition of myxomatous tissue, where we see in hypothyroidism. Sometimes drugs can also be associated with edema, most commonly non-steroidal anti-inflammatory drugs or some anti-diabetic drugs like pioglitazones. Insulin can also cause. Steroids, they are associated with glucocorticoids, mineralocorticoids can cause fluid and water retention. And calcium channel blockers sometimes, especially with previous generation calcium channel blockers like difedipine, patients tend to have edema. And vasodilators also can cause edema. So these are the common drugs like NSAIDs, and these are drugs also can cause edema. So whenever the patient comes with edema, we need to look at the drug chart before evaluation. So these are the common causes: congestive heart failure, cirrhosis, and renal condition. Renal condition, chronic kidney disease, or sometimes protein losing conditions like nephrotic syndrome, where patient can have accumulation of fluid in the legs, and patient typically presents with pedal edema. And sometimes systemic diseases like any protein losing enteropathies or hypoalbumic conditions also can present edema of the legs. So whenever these are the common conditions causing edema. So how do you evaluate a patient with edema? So detailed history is important. Whether the patient is taking any drugs are important. And edema, how it is progressed. First, whether it is started in the legs and progressed to the abdomen and then generalized anasarca, or whether initially they presented with abdominal swelling, which gives a clue that patient may be having an underlying liver disease. When the patient is having predominantly breathing difficulty, cardiac symptoms, then edema developments, it could be a primary cardiac cause. When the patient is having associated frothy urine or decreased urine output, that goes more in favor of a kidney disease. So the history is most important whenever the patient is having a edema. So and again we are taking the history whether the patient is having a unilateral, bilateral edema, whether it is a symmetrical, asymmetrical edema is also important. So after the history, we need to evaluate, examine the patient whether the patient is having a pitting edema or non-pitting edema, because that can give clues to the diagnosis, and whether it is unilateral or bilateral. So also examine the per-abdomen whether the patient is having ascites. Look at the JVP and auscultate the lungs. Will give clues whether the patient is having a primary cardiac problem. So after examination, we need to investigate the patient. So routine examination, including a urine examination, look for any protein loss in urine, kidney function tests, especially creatinine with GFR and electrolytes, and liver function tests to look for any liver function abnormalities or any hypoproteinemia, and then ECG 2D echo to look for any cardiac status, and ultrasound abdomen to look for any ascites. So these are the causes of generalized bilateral pitting edema. When you are suspecting any unilateral edema, any venous insufficiency or venous thrombosis, we need to go for a venous Doppler of the lower limbs to look for the rule out the venous causes. So these are the commonly performed tests to know the causes of edema. So how do you manage a patient with pedal edema? So management is definitely, we have to identify the cause of edema and treat the definitive cause, like whether the patient is having a primary cardiac failure. So we need to, again, treatment depends on the what is the cause of cardiac failure and the definitive management of that. And whether the patient is having underlying liver disease, again, treatment depends on the liver disease. So we need to identify the cause of edema and treat. And for temporarily symptomatically, we need to give dietary modifications and treat this excessive salt and water retention by giving a diuretics. So we should always tell the patient to have a low salt diet and restrict the water intake whenever the patient is having edema. And we need to instruct them when they go for a bed, we need to keep the limb elevated to avoid more edema. And treatment of symptomatic treatment includes the diuretics. Diuretics are the drugs which can remove excessive water and salt from the body through the urine. So most commonly used diuretics are what we call loop diuretics. Among them commonly used are furosemide and torsemide. So furosemide available as oral as well as IV formulations. So whenever there is a quick relief is required, we need to give the IV preparation, or else we can give oral tablets, the Lasix or furosemide, which is available as 40 mg tablet. So when we are giving diuretics, diuretics are associated with some complications, like they can cause hypokalemia, metabolic alkalosis, hypomagnesemia. So we need to monitor that. We need to give excessive dose of diuretics, which can cause, again, associated with complications. So we need to daily weigh the patient, and we need to target the weight loss should not be more than half a kg per day, even with patient with severe NSRK. So these are the diuretics, and when loop diuretics doesn't work, we need to add another group of diuretics like potassium sparing diuretics, which is commonly used as the spironolactone, or other group of diuretics which act as the other sites like metolazone, which is additive effect to these routinely used diuretics. So ultimately, the treatment remains on the identifying the cause of edema and treating the primary etiology causing the edema. So to conclude, the edema is accumulation of fluid in the interstitial space. So we need to evaluate whether it is a unilateral, bilateral. Bilateral pedal edema is generally associated with systemic diseases like congestive heart failure, liver failure, and kidney diseases. Identifying the etiology is most important, and many times people will ignore this could be a normal phenomena, but sometimes we may be missing the major diseases like chronic kidney disease, where patient presents to us with advanced renal insufficiency, where the treatment options are limited. So identifying the edema at the early stage and treating it, evaluating and identifying the cause is the utmost importance, and treating based on the etiology is the most important thing. Thank you.